You know, the NCLEX doesn't just test what you've memorized. It really tests your instincts. It keeps asking you the same critical question over and over again. Is this just a minor thing, or is this a disaster about to happen? And knowing the difference, well, that's all about prioritization, and that's exactly what we're going to break down. So let's put it to the test right now. Imagine your patient's arm is falling asleep just hours after getting a cast. Is that something you just jot down in the chart and move on, or is that the very first sign of a limb-threatening emergency? Over the next few minutes, we're going to unlock the frameworks that turn that moment of doubt into decisive, life-saving action. All right, so the first skill is all about perception. It's about learning to see that one critical warning sign, the signal, that's kind of hiding among all the usual expected stuff, what we'll call the noise. Think about these two scenarios. You've got a patient on albuterol who feels a little jittery. Okay, that's noise. It's a totally expected side effect. But our patient with the cast, the one whose arm feels like it's sleeping, that is the signal. That tingling, paresthesia, is a screaming alarm for a potential compartment syndrome. This whole thing follows a progression we call the 6 Ps of compartment syndrome. Now look, by the time you get to a weak pulse or paralysis, those are late signs. The damage might already be done. The real life-saving secret here is this. Paresthesia, that simple tingling feeling, is your very first and your absolute best chance to jump in and prevent a permanent injury. And this whole signal versus noise idea, it applies literally everywhere. A patient taking metronidazole says they have a metallic taste in their mouth. That's noise, a well-known harmless side effect. But a patient on lithium who suddenly starts having blurred vision, that's a critical, high-priority signal. It's not just an inconvenience. It's a direct warning of serious toxicity. And here's exactly why that signal is so incredibly urgent. Lithium has a super narrow safe range, right? Just between 0.6 and 1.2. Blurred vision doesn't mean the level is just a little high. No way. It means the patient is likely in a severely toxic state, maybe at 2.0 or even higher, and they're at immediate risk for a seizure or even a coma. Okay, let's talk about a different kind of emergency, extravasation. This is when a vesicant drug, like chemo, leaks out of the vein and into the tissue. If you see pain and swelling at that IV site, you have to act immediately and you have to be precise. Step 1, stop the infusion. Then disconnect everything, aspirate any drug left in the line, and get the physician on the phone. Every single second counts to prevent that tissue from dying. Now listen up, because this is the #1 most critical mistake you have to avoid. Your first instinct might be to flush the line, to see if it's still working. You have got to fight that urge. Flushing a suspected extravasation is like pouring gasoline on a fire. You are literally pushing that tissue-destroying drug deeper and deeper into the body, making the damage so much worse. Okay, so we've covered how to spot a single emergency. But what happens when you have multiple patients and they're all in crisis? This is where having established frameworks becomes your lifeline for deciding who needs you right this second. In a mass casualties situation, you anchor yourself with the START triage system. Every single victim gets sorted into one of 4 categories. But here's the rule that feels kind of counterintuitive at first. Your priority isn't who is the sickest, it's who is the most salvageable. And here's how that logic actually plays out. In a disaster, your resources are stretched thin. A patient who isn't breathing is tagged black. They're considered unsurvivable. Your very limited resources have to go to the red tags, patients who are in critical condition but who can be saved. That's why the patient with a crushed leg and no pulse gets your attention right away. You can probably save that limb, and you can save that life. Now let's bring it back to the hospital floor. For your day-to-day prioritizing, the most powerful tool is often the simplest one, the ABCs. And it always starts with A for airway. I mean, if a patient can't get air in, nothing else you do is going to matter. Is that airway open and clear? That is always question #1. Next up is B for breathing. An open airway doesn't do much good if the patient isn't actually breathing effectively. So you have to ask, is their breathing too fast, too slow? Are they using accessory muscles? This is your second absolutely non-negotiable check. And finally, we have C for circulation. Is the heart pumping the way it should? Is blood actually getting to all the vital organs? This simple ABC framework is the reason a patient having an acute asthma attack, a direct threat to their airway and breathing, will always be the priority over a patient who has a stable, chronic circulatory problem. The ABCs just cut right through all the noise. All right, let's move on to some more complex situations. These are the ones that don't just test your clinical judgment, but also your understanding of your professional role and how to spot when a known condition is about to spiral out of control. Okay, so the crucial word here, the one you really need to latch onto, is new. Let's say you have a patient with a known diagnosis of placenta previa. The classic sign is painless bleeding, right? But if she suddenly starts telling you about new lower back pain, that is a massive red flag. That new symptom is a huge signal for a potential placental abruption, a totally different and way more catastrophic emergency. We can apply that exact same logic, that watch for the new symptom logic, to endocrine emergencies. Take diabetes insipidus, or DI. Basically, the body's just pouring out water, which leads to some serious dehydration. And this concentrates the blood, causing dangerously high sodium levels. We call that hyponatremia. And this is the critical connection your brain has to make. When that severe hypernatremia kicks in, it literally starts to dehydrate the brain cells. And the very first sign of that? Sudden, new onset confusion. A DI patient who suddenly becomes confused is having a neurological emergency, and they need immediate help. Finally, let's talk about your scope of practice. A parent has some last-minute doubts about their child's surgery. Your role here is not to reassure them or try to re-explain the procedure. Your legal and ethical duty is to be an advocate, and that means you pause everything, you figure out their specific concern, and you notify the surgeon. Only the person who got the consent in the first place can address those new doubts. So we've gone over how to spot emergencies, how to prioritize them, and how to handle these really complex scenarios. Let's boil it all down into 3 golden rules that are going to be your compass on the NCLEX, and honestly, for the rest of your career. First, always remember paresthesia. That sleeping limb feeling is not a minor thing to brush off. It is the absolute earliest warning sign you will get for compartment syndrome, and you have to act on it immediately. Second, always prioritize the new over the expected. It doesn't matter if it's sudden back pain in a patient with placenta previa or new confusion in a DI patient. A new symptom is a potential complication until you can prove it's not. It always jumps to the front of the line ahead of any stable known condition. And third, if you see pain and swelling at a vesicant IV site, your brain should just scream extravasation. And your action should be an automatic sequence. Stop the infusion, aspirate the line, and never, ever flush it. So there you have it. You've got the playbook now for turning chaos into clarity. You have the tools to see the signal in the noise, to prioritize when you're under pressure, and to act decisively. The only question left is, when those alarms start going off for real, which one of these life-saving rules will you remember first?